All right, it's time for another video. I didn't make one for a while because I'm always kind of nervous recording at home because I know other people can hear me talking, but it's definitely time to make another one, and let's get straight into it. So recently I made my guides and I posted them on our residency, and they ended up making this compendium of practical guides for our residency. And of course, yours truly has all of his guides linked in here, which was pretty fun to see. And obviously I got a lot of internet points, like 500 upvotes, 250, 100. So people really enjoyed it, and I really enjoyed posting it and then seeing the discussion that came about, because I feel like it really is something that was missing in this residency subreddit, and I can learn so much when I hear what other people's practices are, and it's really nice to see how other people approach common problems. So I wanted to just go over quickly 12 things that I learned from posting my guides onto Reddit, and just go over some of the highlights from some of the comments. So number one is for insulin regimens for noobs. First thing that I learned on this one is, let's see, the risk of metformin causing lactic acidosis is essentially zero if the kidney function is normal. And if you go down here, there was another endocrinologist attending who mentioned that metformin can be safely continued. Metformin doesn't cause lactic acidosis except an overdose. Either way, the conclusion here is metformin continuers rise up. So this is something that I'm going to think about doing a little bit more frequently in my inpatients, is continuing some of their home oral antihyperglycemics. And point number two is basically for stable patients who are taking PO and have good kidney function, they are probably better served by continuing some of their home meds on admission, or at least resuming them prior to discharge once stable. The next thing that I learned was the rule of 1500 or the rule of 1800, which I kind of knew before already, but this was a really good reminder and something that I added to the guide. But basically, the rule of 1800 is a method that you can use to figure out how much one unit of insulin is going to alter somebody's glucose by. So for example, if you use the rule of 1800, you do 1800 divided by the total daily dose of insulin. And for example, if somebody's using 60 units of insulin, that tells you that each unit of insulin is actually decreasing their glucose, or would be expected to decrease their glucose by 30 milligrams per deciliter. And so this is a really good way to figure out how much insulin your patient would be able to tolerate if you're going up on their insulin or titrating up, for example. The next thing I learned was that, I had written that SGLT2 inhibitors cause an increased risk of UTI, but I think there's a bit of a nuance to this. It doesn't actually cause an increased risk of UTI, and there's actually several papers that discuss this. But actually, it shows that, there is an increased risk of genital yeast infections, primarily in women, but also fungal balanitis in men, particularly in uncircumcised men. And I actually saw that in one of my patients in the outpatient setting. So it's actually incorrect to say that SGLT2 inhibitors are going to increase the risk of UTI in your patients. Another thing to remember is, more importantly, they drastically increase the risk of euglycemic DKA. So that's something to be definitely on the lookout for when you have a patient on SGLT2 inhibitors. But again, if they're a stable patient and their creatinine's pretty good and they're doing pretty well overall, then you can consider actually continuing SGLT2 inhibitors while inpatient. And this is definitely a trend that's probably going to be hitting the hospitals more in the future. There was this endocrinologist who actually corrected my weight-based dosing formula. It wasn't really based on if the patient was skinny or obese, but more based on this criteria that was published in the Endo Society journal. So if they're age greater than 70 or they have a bad EGFR, then you would do the lower range of insulin dosing. If their glucose is 140 to 200, then you would do 0.4 units per kilogram, 200 to 400, 0.5 units, and then for steroid-induced hyperglycemia, 0.6 units per kilogram per day. And I think this makes a lot more sense than what I had initially written, which was basically obese patients, you give 0.5 units per kilogram, thin patients, you give 0.3. I think this is a much nicer way to look at it, and I'm excited to use this instead moving forward. Next, moving on to my pain regimen guide, I learned quite a bit of useful things in this one, including some surgeons that were commenting, and I learned a lot about like post-op surgical management, which I'm not going to post in here, but there's a really good post by MMO surgeon who's a very prolific guy. You can learn a lot about nerve blocks and the other things that they do, but there's a few important things that I learned. One of the big things is that for Toradol, 15 milligrams is equivalent to 30 milligrams in terms of pain relief, and actually 10 milligrams is found to be equivalent to 15 and 30 milligrams. Basically, the vials come in 15 and 30 milligram doses, doses though, so it's pretty common to just give 15 milligrams. But now after knowing this, I'm definitely only going to prescribe 10 or 15 milligrams. You know, the less medicine we can give but achieve the same effect, the better. I also learned lidocaine patches, 4% and 2% formulations are very readily available over the counter. It's just the 5% prescription one that's kind of difficult to get as an outpatient. And then here's MMO surgeon's post about all the surgical management. And one common theme you'll see in this entire Reddit thread is the utility of placing everything as a standing or scheduled dose, especially Tylenol, especially NSAIDs. You basically want to put everything standing before you start reaching for PRN opioids. And that's something that I really don't think I did very much. I basically always had PRN Tylenol, and then NSAIDs I avoided quite a bit, but now I've seen that a lot of people use it, especially in the post-surgical setting, and it actually gives me some relief to know that I have like another option to reach for before surgery. Obviously, I still have to worry about AKI or GI bleed. But a common theme throughout this thread is continue to do standing doses. So 15 milligrams of Toradol every 6 hours standing. You got your Tylenol, which should be 1,000 milligrams Q8 hours, not PRN, as he talks about here. And so basically, just schedule your medications more and it will be very effective in controlling patients' pain. This guy, vitamin H Deficiency, he's an attending, and he posted a ton of useful information. But one of the big things that really was nice for me is that he confirmed that Tramadol is a garbage drug and should be universally avoided. Basically because there's a lot of problematic drug interactions, it lowers the seizure threshold. He states it is not a consolation prize, less dangerous opioid like some will claim. It has all the risks of dependence, diversion, addiction, and overdose associated with the entire drug class. The other thing I learned from his post is that my statement about methadone and QT prolongation was incorrect. I actually wrote that QT prolongation does not happen with oral methadone, while it does with IV, but it does look like oral methadone does prolong the QT as well. And in general, you have to be very cautious with methadone and definitely get pain management involved if you're going to be thinking about something like methadone. Just some other things. He said he agrees wholeheartedly about muscle relaxants. They do not relax muscles. They sedate patients and make them too drowsy to care about their muscles. There is no high quality evidence that they may help with undifferentiated musculoskeletal pain. I like to joke that there are 3 real kinds of muscle relaxants: succinylcholine, non-depolarizing neuromuscular blockers, and dantrolene, and we're clearly not giving these to people with back spasm. Another thing that MMO surgeon wrote is oral medications always work better and last longer than IV pushes or PCAs. So if your patient is appropriate for oral medication, use that. That's something that I'm definitely going to push as an idea moving forward. If my patient's requesting IV, I'll let them know that, oral medications actually are more effective. So if you can take the oral version, we should start with that instead of trying IV, which is not as effective. Interesting note here that one of the anesthesiologists or surgeons, they were linking some articles showing that Toradol actually does not increase bleeding risk in peri-surgical patients. Next, I learned a useful thing about long-acting versus short-acting opioids and when to combine them. And this reply from Dominus Anolurum. I wonder why his name is Brown, by the way, but he says you really should never use long-acting narcotics in the standard patient population. They have high abuse and overdose potential and don't really work well for most acute or chronic pain issues. Their role is really in pain related to cancer or end-of-life related pain. In cancer patients, you will often see them combined with short-acting in a manner similar to basal bolus insulin regimens. Something I didn't know, so today I learned. Then we got some appreciation posts down here. Hey, it's Suppy. And great guide. Nice. Strong work, strong work. And God, you are so sexy dumping knowledge on me right now. I appreciate your comment, Thorin Stumpin' Shield. Next, I have my bowel regimens, which I kind of already addressed some of the things that I learned from there. Basically, MMO surgeons recommended putting bisacodyl suppository a little bit higher, basically the second thing in the algorithm after Miralax and Senna. So I'm definitely going to move that up on my bowel regimen algorithm. Some people brought up coffee, which is something I totally forgot about. And that's a really easy and more natural way to get somebody to stimulate their bowels. And then we had a little bit more of a discussion of the sugar-free Haribo bears. Sorbitol is one of the main reasons that certain things are laxatives, like prune juice, like some of these gummy bears. And even sometimes when I eat a lot of sugar-free gum, I actually get kind of a laxative effect because it's got a lot of sorbitol and xylitol, stuff like that. And then finally going on to electrolyte repletion for noobs. I think most of my stuff was pretty accurate and people didn't have too much to say about it, but they definitely said check your institutional algorithms for replacement protocols. MMO surgeon, again, commenting on here, if patients are stable, eating, and close to awaiting discharge, do not order labs. Do not order labs. And this is interesting because there was a whole debate between internal medicine and surgery after this post. And basically surgeons were saying that after you fix their acute surgical problem, their body's going to fix themselves. You don't got to keep checking it. But then IM was like, well, you got all these 70, 80 septuagenarians or whatever they called them with tons of comorbidities, and their bodies aren't going to correct themselves. So it is still important to keep checking. So I think this kind of depends on what kind of patient population you're dealing with. But in general, there is the choosing wisely advisory about not checking labs for no reason. So definitely we need to be more thoughtful when we're choosing whether to get daily blood draws on many of our patients. And then I guess the last thing that I learned was that you can give magnesium gluconate orally to avoid diarrhea, which I did not know because I thought only magnesium oxide was the option, but it has a really bad laxative effect. So another today I learned. So anyways, those were just a couple of the tidbits that I learned from my Reddit guide posts and the discussions that ensued after that. And I'm really excited to keep posting more. You know, it's been like 9 days since I posted the last one, so I need to post some more soon. It's just I've been a little bit behind on the videos, so I'm going to post them soon, get some more feedback, learn some more new things. It's great having the internet as a resource because we're not exposed. Like there's no way you can be exposed to everything in medicine, and you're not going to be able to be taught everything in medicine at your own institution by yourself. There's no way you can see everything. But by going online, you can elicit the opinions of other people who have seen very different perspectives on how to do things, and they've seen different patient populations, they've seen what's worked and what hasn't worked. And so it's really useful to have this community where we can basically brainstorm the best ways to approach common practical issues in the hospital. So I'm looking forward to that. I'm going to make some more videos soon, and thanks for watching.